Hey, I'm Dr. Scott Werden, the TOS guy. Welcome to the next in our series of educational videos on TOS education. The title of today's talk is The Role of Diagnostic Imaging in Thoracic Outlet Syndrome. First of all, I want to thank you all for attending. We've had several questions about this exact subject. I plan to introduce it on a basic level. You don't have to be a doctor or a medical student to understand this. I'll try to use as many simple words as I can so we don't get into the battle of medicalese with all its fancy terms. Of course, some of those words will be necessary. But let's get started. There'll be plenty of time for questions at the end. Here are three basic questions we're going to ask and try to answer. What imaging tests are available for TOS patients? What are the advantages and disadvantages of each test? And how would your doctor or you choose an imaging test if you think you have thoracic outlet syndrome? Here are the basic modalities we're going to look at: X-rays, arteriography, venography, ultrasound, CAT scan or CT, and MRI. First, I want to review something. Thoracic outlet syndrome's definition. My definition is just what you see here. Thoracic outlet syndrome occurs when there is symptomatic compression of the arteries, nerves, or veins that pass through the thoracic outlet. In other words, that compression can occur without symptoms. That's not TOS. But when you do get symptoms, and we can show compression or tension on these structures, you have thoracic outlet syndrome. There are three types of thoracic outlet syndrome: arterial, venous, and neurogenic. Now, by far, the most common is neurogenic. 95% of all cases of TOS are neurogenic. These are the cases that are tough to diagnose, and that's why imaging becomes more and more important in neurogenic TOS than in the other types of TOS. But bear in mind that when we see a patient with neurogenic TOS and we see compression or tension of the brachial plexus, we often see some compression of the arteries and the veins. Therefore, it's pretty important to get an idea of all the structures that pass through the thoracic outlet if we're going to do imaging. Now, the clinical diagnosis. When you see your doctor in his or her office and he or she examines you, they may do some tests. If they know a little bit about TOS, they'll try tests like Adson's test or the Wright test. But these tests don't work very well for a number of reasons. When they were first developed, we didn't have imaging. Adson test in particular is about 100 years old, from the 1920s. He didn't have ultrasound. He didn't have MRI. He didn't have CAT scans. His test is actually pretty clever, but now it's outmoded. And the premise that he made, that he based his test on, just isn't very accurate for right now. So these tests will point you as a doctor in the direction of the diagnosis of thoracic outlet syndrome, but they don't tell you exactly whether you have thoracic outlet syndrome or not. In other words, they can't pick up a lot of cases where TOS is really there, and they can't rule out TOS when it's not really there with any high accuracy. In addition, they don't tell you what the underlying structure is that's causing the compression of each of these structures. So remember, the underlying anatomy, as we've discussed before, of the thoracic outlet syndrome, the thoracic outlet, is very complex. There's a lot of unusual soft tissues. The brachial plexus is complex. And when you add in movement of the neck and the arms, this anatomy and the spaces for those structures becomes even more complex. It's a tough disease to diagnose. Let's start with X-rays. Everybody's seen an X-ray. This, from 1895, is actually the very first medical X-ray produced by a guy named Wilhelm Conrad Röntgen. And this is actually an X-ray of his wife's hand. That's pretty amazing. At the time, people were just flabbergasted. You could see these bones in a living person. This is a very early chest radiograph called a skiogram. Well, what these tests showed around 1895 and into the early 20th century was a patient could have a cervical rib. If you look here on the left side of the screen, the right side of the patient, the structure labeled A is a cervical rib. When patients showed up with symptoms of neurogenic TOS or arterial TOS, a doctor could get a skiagram, or what we call a X-ray or a radiograph, and they could see this cervical rib. And so this is what led to the cervical rib syndrome. Now, today's chest X-ray looks a lot better than that, and we can see a lot more detail. This patient happens to have fairly large bilateral cervical ribs. And here's an example of an X-ray of your cervical spine, maybe. And we can see a small right and larger left cervical rib. That's all great, but the problem is we don't really see soft tissues very well. Now, this is from just a couple of years ago, from 2016, and the Society for Vascular Surgery is a very prominent society. Vascular surgeons, keep that in mind, and vascular surgeons in particular. We can see some famous names in their field as the authors, and they wrote a position paper on how to evaluate and diagnose and treat thoracic outlet syndrome. When they talked about arterial TOS and venous TOS, which are pretty easy to diagnose, they would recommend ultrasound or CAT scan or MRI. But when it came to the difficult neurogenic TOS, this is what they said. A chest radiograph or cervical spine series should be performed in all patients, and the presence or absence of a cervical rib or an elongated C7 transverse process should be reported. That's all well and good. Cervical ribs may cause TOS, but an X-ray can't show the brachial plexus. It can't show the subclavian artery or the subclavian vein. So we have no idea whether any of those structures is being affected by a cervical rib. And allow me to say it a different way. We know that about 0.5% of the population has a cervical rib, sometimes two. But we also know that many people don't have TOS. We don't see 0.5% of the population walking around with TOS. We don't know that number. But there's clearly no correlation between the cervical rib and the symptoms. Cervical ribs most often occur incidentally, meaning I, as a radiologist, might read a chest radiograph for pneumonia, and I'll see a cervical rib, and I'll report it. That patient doesn't have TOS. So here's an example I often give when I do a conference. There's a patient on the left side of the screen. There's a patient on the right side of the screen. I want you to raise your hand if you think one of these patients has TOS. You can raise your left hand if you think the patient on the left has it. Raise your right hand if you think the patient on the right has it. Okay? Now let's say I tell you that the patient on the left has thoracic outlet syndrome. Well, they've got an elongated C7 transverse process on their right side, and they've got a cervical rib on their left side. Can you tell me which side their symptoms are on? Well, I'm sure all of you are just kind of rolling your eyes right now because you can't tell. But I, on the other hand, with 20 years of experience, I can't tell either. So an X-ray really doesn't provide a lot of help. It has certain advantages. It's widely available. Any hospital, many doctors' offices, they have X-rays. They're easy to read. Almost any radiologist can read them. You don't need special training. And they provide the patient with some radiation, but it's a pretty low dose of radiation. The disadvantages of an X-ray are that they demonstrate two dimensions only, left and right, up and down, depending the angle you took the X-ray. They don't show the depth from front to back where something is located. They also just primarily show bone. They show a little bit of soft tissue, but it's very hard to distinguish a nerve from a muscle. You can see fat a little bit. You can see soft tissue gas. It's not great for this purpose. And then again, there's a little bit of radiation. If you get a lot of X-rays, you can start getting concerned. A few X-rays doesn't matter. Let's go on to the next test that used to be used a lot. It's called arteriography, or pictures of the arteries. This is a little series of plastic catheters that we use nowadays. We'll take this catheter and we'll put it inside the artery of the patient, and then we'll inject this X-ray dye or contrast, and then we'll see where the blood flows because the blood is now mixed with contrast. Here's just a graphic of that. You can see that either in the groin area where there's an artery or the wrist area where there's an artery. We make a puncture with a needle right through the arterial wall. And then we guide in this catheter and we start threading it forward up the artery until we reach the area we want to see. And after we reach the area we want to see, under X-ray, here you see the doctor standing, the patient laying down. You see a sterile field with blue gauze or paper over the patient. And you see an X-ray tube suspended over the patient with the X-ray images projected on the back wall there. Here's an example. This is a catheter that came all the way from the artery in the leg, and it's way up near the heart in the aorta, the largest vessel in the body. And when you inject contrast, it can show up white or black. That's not important, but you can fill the arteries, and you can see the arteries separate from everything else. So it's a neat little trick. And in the past, patients with neurogenic TOS could get one of these. They would take pictures of the subclavian arteries, for example. And if the artery was compressed, the doc would assume that the brachial plexus was also compressed. Now, this is a pretty big assumption, it turns out, but for a while, this was the best test they had. This is also what Adson's test is based on. Adson's test tries to compress your artery while the doctor feels the pulse at your wrist. And if you can make the pulse go away, you assume that the artery up here, the subclavian artery, is being compressed. And then you can assume on top of that the brachial plexus is being compressed. But it's a lot of assumptions and it doesn't work out so well in real life. Here's a picture of a selective arteriogram where the dye or contrast is injected into the right subclavian artery. It's on our left, but you can see the subclavian artery and its branches are black. And then here's a picture of a diseased or compressed subclavian artery. So in this case, we know the artery is being compressed. We're assuming that the brachial plexus is being compressed. But again, I would warn you, that does not work so well. So what are the advantages of arteriography? Well, it clearly shows the arteries in very high resolution. That's great. It can show the veins if you wait long enough. The contrast or the dye goes through the arteries, gets to the soft tissues, and starts heading back to the heart. And then you start to see veins. It's not the best picture of the veins, but certainly enough to see what's going on for anything large. The arteriography disadvantages are just like an X-ray. It's only two dimensions. We can't see in front and in back. We can see side to side, top to bottom. It shows us the vascular structures, the arteries or the veins, and the bony structures, but it doesn't show the soft tissues very well. It gives you ionizing radiation, or the radiation you get from an X-ray, but it's a moderate to high dose of it. And when you inject this dye or contrast, you can affect kidney function. In fact, it goes the other way too. Patients with poor kidney function should not get that dye or contrast. It may make the kidneys fail. Let's go on to the next test. It's called venography. Now, I got from a Dr. Paul Gamboa in Argentina a really awesome pic. This is actually a video of venography. Now, this looks like a chest X-ray. What you're going to see is they've actually put little catheters into the veins of the patient in the crook of each elbow, and they're going to inject X-ray dye or contrast. And what you're going to see, the beating heart, and slowly the blood from the veins is going to come back towards the heart. All right, and you can see it flow in. You can see on the right there's a whole bunch of extra veins because when the patient raises their arms, there's compression. You can't see anything coming through that vein that's on your left or the patient's right. So this is pretty neat. We don't see these too often because in this country we have other tests. But Dr. Gamboa showed me this, and this is the test that they have to use. It's really kind of a cool picture for me. So what are the advantages of venography? Just like with arteriography, they show the veins with high resolution because we're pouring this dye or contrast into them. We can sometimes see how fast the blood flows or the kinetics, but we can get an idea if the blood is flowing very slowly or if it stops flowing. The disadvantages are, again, it shows us two dimensions only. It shows us the vascular structures or the veins and the bones, but not much soft tissue. It can give you a moderate to high dose of ionizing radiation. And again, because we're injecting the dye, it may affect kidney function. Also, some patients, if they don't have great kidney function to start with, may not be able to get this test. Let's move on to ultrasound. Many of you may have had ultrasound. We know pregnant ladies get it. We know people with blood clots in their legs get it. Ultrasound is a pretty widely used test. It doesn't work with X-ray, so it doesn't provide radiation. Now, here's an example of an X-ray. Sorry, this is an example of an ultrasound in the thoracic outlet. AS means anterior scalene. MS means middle scalene. And then you see the nerve roots are outlined with little dots. Well, the reason they're outlined is because ultrasound isn't great at separating nerves from muscles. It's good, it's okay, but it's not really great, especially if the nerves go through the muscles or take an unusual course. Also, it cannot show bones at all. It's completely blocked by bones. Now, what ultrasound is good at is real-time imaging. You could actually have a patient move while you're watching. X-rays can't do that. These two pictures are at the same level. On the left side, you'll see there are two black holes. Those are blood vessels. One is an artery, one is a vein. And the picture on the right shows ultrasound measuring blood flow. You can see one of them is predominantly blue, that's the vein here. One of them is predominantly red. My mistake, actually, the blue one happens to be the carotid artery. And the one that's mostly red is the internal jugular vein. But the point is, you can see blood flow, not only as color, but you can measure the velocity and the turbulence of the blood flow. It's very useful. So there's two pictures here, one at the top above the purple line and one at the bottom. And they both measure the same thing. They're measuring the axillary artery, which occurs right after the subclavian artery. It's between the rib and the clavicle. That's the subclavian artery. And then the axillary artery occurs. On the top, you'll see the top picture to the right. There's a little waveform. Looks like a sonar that you see in war movies when they're showing a submarine using its sonar. The bottom picture, below the purple line, you'll see to the right, these big gray triangular shapes. And what's happened here is the top picture shows this axillary artery with the arms with the arms down. And the bottom picture below the purple line shows the axillary artery with the arms up. And what's happening is the artery is being highly compressed and the blood flow is squeezing through that narrow area like a garden hose when you put the thumb over the end. So it's a very high velocity and it's very turbulent blood flow. So this is good. It's real time. It shows us the artery is being compressed and it doesn't need the radiation that an arteriogram does. And it doesn't require the dye or contrast that the arteriogram does. The only problem is this. We're seeing the artery being compressed. Does that mean the brachial plexus is compressed? No, we don't know that. And ultrasound, since it's blocked by bone, cannot see into that space between the rib and the clavicle, a very important space. So if you can't see that, you're taking secondary information like this and going backwards and judging whether the brachial plexus is being compressed because the artery is. Well, we don't know that. And I can tell you from my experience, compression of the artery does not equal compression of the brachial plexus. So ultrasound has advantages. You can get all three dimensions in any plane that you pick. It's real time. You can watch things moving underneath the ultrasound probe. There's no radiation, and you don't have to give contrast. But the disadvantages are it's highly user dependent. If you have a sonographer who's not really skilled at this particular thing, he or she may not be able to get you the pictures you need as a radiologist. Also, any bone or gas will block the ultrasound. You'll get no imaging deep to the surface of that. So it's very limited for certain areas. And then it has somewhat limited soft tissue differentiation. It can show fat from muscle, but it has trouble showing nerves from muscle. So it's in the medium range, but not the highest differentiation of soft tissues. Now let's move on to CAT scan. Everybody's heard the expression CAT scan. These are slices through a CAT scan at about the same level in a patient. It's kind of like taking a knife and slicing through your body like a loaf of bread and making slices like this. So on the image on the left, we can see the heart and the blood vessels are in the center of the chest and they're bright white. We can see the bones or the ribs around the edge of the chest, and they are bright white. Around the ribs, we can see the muscles, which are a medium gray. And around the muscles, we can see fat, which is medium to dark gray. It's pretty good. We can also see the lungs, or just the black areas in the middle. Now, the image on the right, if you manipulate the image on the left, you can now make the lungs show up, and you can see the structures within the lungs. That's great. Now, you see that the bones and the muscles and the fat are all kind of a light gray, and they're harder to distinguish from one another. CT can also be used to look at bones. Look at the fine detail you see in this bone right here. It's great for that. So with CT, we can see soft tissues with some differentiation. We can see the lungs, we can see the bone. You can also manipulate images. If you inject dye, like we do for an arteriogram, you can get pictures like this. We see a curved, large vessel right in the center of our picture. That's the aorta, the large artery in the body. And we see some arteries branching off of it, going up towards the top of the image. These are the subclavian arteries on each side. We can also see the bones are fairly white, bright, and we see that they come into close contact with the subclavian artery on each side. So that's good. Arteriograms can really show blood vessels quite well and can show them in 3 dimensions. And it can show the bones separate from the other soft tissues. You can also take slices and put them together like a jigsaw puzzle and then slice it another way. So we see the bones. This is the cervical spine. Excuse me one second. From top to bottom, this is the cervical spine. I hope you appreciate that you see great bone detail. You can find fractures quite easily with this. You can also turn it into a 3-dimensional picture like this, where the surfaces are well seen. So this is part of the cervical spine. If you look to the right of the picture, you'll see a fairly large cervical rib. And you can take this model you've created and you can rotate it in all kinds of different planes. So for surgeons or docs who aren't used to looking at images all day like a radiologist, this can be quite helpful to demonstrate complex anatomy. So the advantages of CT are it's widely available. It's available in most hospitals and emergency rooms. You can see all 3 dimensions in any plane that you pick. Once you acquire the images, you do what we did on some of these earlier images and you stack them together in different directions and you manipulate that data to create very nice pictures. It can have fair to good soft tissue differentiation. But again, it's a little difficult on CT to separate the nerves from the muscles. And this is pretty important in TOS patients. CT can produce excellent arteriograms and venograms. And in some cases, many cases, you don't need to administer contrast. That's good. But the disadvantages are, again, as I said, there is some limitation in the soft tissue differentiation. We can't separate out the brachial plexus from the other structures very easily. It provides a moderate to high radiation dose, and we're all being conscious of how much radiation we give to patients. You do require contrast for some applications. For example, to make those nice arteriograms, you do have to admit to the patient this contrast or dye. And that last line, that the contrast may affect kidney function, is true. So the same thing as with a direct arteriogram or a venogram. When you give contrast, you have to be very mindful of the patient's kidney function. Some patients may not be able to get this dye because they have kidney function that's not great. Now let's move on to MRI. MRI works on a different physical principle than CAT scan or X-ray or angiogram or venogram. It doesn't use X-rays. It uses high-strength magnetic fields which generate radio waves, and then the radio waves are read and interpreted by the computer, turn them into images. This is a simple slice through the neck. And hopefully you can see in this that the fat is white, the muscles are dark gray, the bones are kind of a medium gray. You can even see the spinal cord in the center of the picture. Don't worry about these individual structures, I'm just showing you an example. This is a different MRI slice where the fat is white, the muscles are dark gray, the bones are white in the middle with a black shell around them. You can see an artery, which is just a black circle, a vein, which is just a black circle, because in this particular type of MRI, the blood vessels are left to be dark. Again, I hope you appreciate how you can see the different soft tissues. I can actually see 3 separate parts of the brachial plexus as a medium gray. They're darker than fat, but brighter than muscle. This is tremendously useful. We can do arteriograms and venograms with MRI. On the left side of your picture, you'll see an MR angiogram or MR arteriogram. The blood vessels look great. We've injected a different kind of dye, not an X-ray dye, and you can see the vessels of the neck and the chest and the arteries going out to each arm. There's very little tissue behind it. We've gotten rid of most of the other tissues, so you can see just the blood vessels. That has advantages and disadvantages. When we look at the right side of the screen, you'll see a venogram, which was performed after this arteriogram. We just waited a little while and took more pictures. Now you can still see the arteries, but you also see the veins. So this is very useful as well. In many cases, I'll see the veins bringing this dye back from one arm, but not the other. And that kind of kinetic or time information tells me that the blood flow is slow coming back from one arm. It's very useful. You can take an MR arteriogram, and right in the middle of the picture, you can see that it looks pinched, and it is pinched. This is right between the rib and the clavicle. Even though you can't see the rib and the clavicle on this image, we can see them on other images from an MRI performed at the same time. You see that? It's pinched very tight, and the artery is a little bit dilated, just distal to that. And here's a picture of the brachial plexus on each side. We can lay out the brachial plexus, separate it out from the rest of the soft tissues. No other modality can do it this cleanly. The brachial plexus are these white cables or wires you see. There's 5 of them on each side, and they spread out from the spinal column, and they go into each arm and join together where they split and branch and rejoin again. Then they form the 5 nerves that go into each arm. This is just a picture with the left side and the right side. What you'll see here is a normal person. On the left side, we can see the white fat. We can actually see the blood vessels, the brachial plexus, and the collarbone and first rib. On the right side of this, you'll see their arms are up. The left side is with their arms down. And this is one of the ways that we can tell whether arm motion will compress the brachial plexus. Again, don't worry about the details. The point of this is to show how well we can separate all the structures out and use dynamic maneuvers on an MRI scan. Okay, the brachial plexus with the arms up is little gray structures. On the right side with the arms down, you can see the brachial plexus is compressed between the clavicle or collarbone and the first rib. So this is very useful information. So the advantages of MRI, it's widely available. Most hospitals have one. You can show 3 dimensions in any plane you want, up, down, left, right, or obliqued. It has excellent soft tissue differentiation, better than any other modality. And it can produce excellent arteriograms and venograms, as we just saw. What are the disadvantages? Oh, we still have more advantages. Isn't that great? Well, we don't need contrast for many applications in MRI. When we do need contrast, it's a different type of contrast or dye. It's not the type that affects the kidneys nearly as much. So often, patients with moderately bad kidney function can still get an MRI with MRI dye. The disadvantages are, number 1, it's a very complex technique. The technique I've developed, for instance, has taken a lot of time to develop and redefine and refine and keep improving. So just having a technologist isn't enough. You need a radiologist to work with a technologist to make this study really sing and show all this great detail. Secondly, there is an artifact that occurs when you inject the dye into the vein in your elbow. It can make one of the subclavian arteries look like it's compressed when it's really not compressed. So you have to be careful of that and work around it. And then motion artifact. Oftentimes, patients can't hold their breath for very long. An MRI acquisition can take 3, 4, 5, 6 minutes, whereas a CAT scan image, you just have to hold your breath for 30 seconds. So the fact that MRI is slower means that if a patient moves or twitches or sneezes or coughs, the images can be severely affected. And then some patients, of course, get claustrophobic. Probably 1% of patients really can't get the MRI due to severe claustrophobia. Other ones can if you give them a sedative. And then in some patients who have a pacemaker or an aneurysm clip of certain types, the older types, they may not be able to get an MRI. Okay, so that is what I wanted to get to here. We've covered each of these in its basics. These are the main modalities that would be used to diagnose thoracic outlet syndrome. As you know, as the creators of NeoVista MRI, we believe that this is by far the best test to use. No radiation, a relatively short MRI examination. We show the blood vessels, including the arteries and the veins. We show the brachial plexus, or the nerves on each side. We show the cervical spine and the spinal cord. We show all these grayscale images to show the fat and the lung and the bones with the arms down and the arms up. And we can put them all together to make a comprehensive picture of what is really going on in this complex anatomic space. So now I'd like to entertain questions. First question I have, is it common for MRI or CT to be misread due to human error? Well, it can happen. And hopefully it's not anything major. So after a radiologist looks at images, the doctor who refers the patient for these images will often look him or herself. And there can be an advantage to that. MRIs are not so easy to read if you're not experienced at it. But I would say it's fairly rare for a radiologist to miss something big. And hopefully if a radiologist misses something, and I have in my career, hopefully they follow up and resolve the issue with it. Is open MRI the same as regular MRI? Thank you for the question, Maria. An open MRI is meant for patients who don't feel comfortable in the tube of the MRI scanner. I've had MRIs myself, and sometimes I've been comfortable and sometimes I've been a little bit edgy about it. So the open MRI feels better. But the open MRIs are by necessity of a lower strength of magnet. Now, the main magnet that we use for an MRI determines how much resolution we can get. In other words, like a magnifying glass, how close can we get? How small a structure can we see? An open MRI can be as low as 0.1 to 0.3 Tesla. That's a measurement of the main magnetic field. Whereas normal, quote unquote, normal MRIs or high field MRIs, instead of being between 0.1 and 0.3, they can be 1.5 Tesla up to 3 Tesla. So they can be 10 times stronger. And that makes a big difference in how well you can see structures and separate them. It also allows us to do better techniques, better angiography. So in general, I recommend most patients go with a high field MRI or a standard MRI, whether it's 1.5 Tesla or 3 Tesla. A side question is I have patients ask me whether our partners use 3 Tesla magnets because they've heard these have a lot of advantages. I would say this, for my purposes, to make the diagnosis of TOS, to provide your doctor with the necessary information, 1.5 Tesla magnet is plenty. If we have a 3 Tesla, we might get some more information, but not at all necessary. Our next question says, some MRI scans do not show the entire arm or the hand. Is this needed? You could, with an MRI, show most of the body in one view. But again, like the resolution question of a low field or open MRI, you're going to lose the ability to see things up close. Imagine you're on a satellite you're orbiting the Earth and you want to look down and you want to see something. We know that the CIA probably has these great cameras that can read license plates, okay, but you can't. If you're flying in an airplane on a trip to Hawaii or Europe, you can look down and you can see the Earth, but it's hard to make out individual houses. When the plane starts approaching the landing strip, you start to see the houses and the streets and the cars. So if we use an MRI with a large field of view, meaning that we take an image of an entire arm, we won't be able to see the fine detail that we need. If the patient has a large mass and we want to see the edges of the mass, we might do that. But in the thoracic outlet, where I specialize, we want to see some pretty small structures. So we don't include the entire head or the entire chest. We try to limit the area we view just to the region of interest, the cervical spine, the thoracic outlet, and just getting into the shoulder. I hope that answers your question. All right. The next question says, my physician says that a CT with contrast is the best tool for vascular TOS. It seems that you think MRI is better. Can you explain? This is Gina from Australia. Okay, so a CT scan has certain advantages and disadvantages in general relative to MRI. To do an angiogram, you have to inject dye or contrast. If your kidneys are in good shape, it's not a problem. If you have a little bit of kidney dysfunction, you have to be careful when you administer this X-ray dye. Also, a CAT scan gives you a pretty high dose of radiation. Not a problem for a one-time scan, but every dose of radiation you get should be thought through carefully. Now, MRI doesn't give radiation, and the dye that it uses does less damage to the kidneys. It's a safer dye to administer. But the bigger differences are once you have the test, what can we diagnose? Now, when I look at images, I've seen so many of them that I know what to look for and I know what I'm seeing, even subtle things. And when another doc who's not a radiologist looks at them, he or she may not be able to see that same level of detail. They don't look at images all day long. They look at thousands and thousands of images. So for them, it's oftentimes easier to get a CT angiogram because the bones are white, the blood vessels are white, the lungs are black. Everything else is pretty much medium to dark gray. So it's a very stark image. You can see the bones and the blood vessels and pretty much nothing else. For some docs, that's easier. You really see very sharp images. When you do an MR, if you look at the blood vessels, you don't see anything else. If you do the best MR angiogram or MR arteriogram, you absolutely won't see anything else. That's the purpose of it. Nothing interferes with your view of the arteries or your view of the veins. Now that means you need to take your eyes off that picture and you look at the other MRI images you got at the same time without the patient moving. So you could look for a little ligament or a fibrous band. You have to look for the rib and the collarbone. You want to look for the scalene muscles. For some docs who don't do this all the time, it's hard to move their eyes from one image to the next and put them together. But I do this all the time. So if I'm interpreting it, MRI for me, to look to one set of images, go back to the other one is a piece of cake. It's what I do. And it does provide more image data in the end. So if I see a scalene muscle that is too big, I can see if it's pressing on the artery or not. That would not be easy to see on a CAT scan. All right. So it's a little bit of a complex question. I appreciate that. And I hope I gave you an answer that makes sense. You can ask further if I didn't. The next question. My wife had a brachial plexus MRI that was done last year to diagnose TOS. It said that she did not have TOS. Could we have you review those images? And this is Jimmy from Arizona. Yes, I am available to consult on other images. Frequently get asked to look at images done at very famous places. In the nicest possible way, I've specialized in TOS for 20 years now. This is what I do. My wife teases me about my obsession, but it's fascinating to me and it's something where I can help a lot of people. A radiologist at an academic center centers I don't need to name. They do great work. I trained at those places. But if they don't have someone like me who really digs into this and is specialized at this, then they might not see the things that I see, and they might not understand the importance of each thing or the non-importance of each thing. When I talk to doctors around the country, when I see surgeries, I learn what they need to know to make good decisions. And so that enables me to provide that data from the same images that a radiologist at one of these academic places just might not have the experience to do. So yes, I'm happy to review them. You can reach out to me through our website, and we'll discuss how we set this sort of consult up. Next question says, are you still performing your unique MRI for TOS during the pandemic? Thank you. Yes, we are. We are fortunate to have some very good imaging partners in different parts of the country. All of them have taken suitable precautions. I've not heard of anybody getting the virus at one of these centers. They've spaced out their schedule so that there's more time between each patient. They wash down and sterilize the rooms, disinfect the rooms that they use. They disinfect the MRI scanner inside and the coils that they put on your body. So I think we all feel safe that we can scan patients during this period. It's still a personal decision. For many people, they say even a low risk of getting the virus is not suitable for me, and my disease isn't so bad right now, so I can wait, and we support that. I want to remind everybody that if you get in touch with us, we don't obligate anybody to get our scan, to get our advice. We have a great team who knows a lot about TOS. We know a lot of people in the country. We're happy to steer people to the right diagnostic test if it's not us, or to the right specialist that's closest to you, or multiple specialists. And of course, as my wife teases, I'm all too happy to talk about TOS. So to get a consult with me and chat a little bit about your case is something we're happy to do. Let's see if there are any other questions. All right. Just got a new one. I had one of Dr. Werden's Neovista MRIs in 2012. The images in today's slide seem to show more detail. Can you discuss how the imaging has improved during that time? Thank you, Michael. The refinements we made over time are in the, let's see, without getting too technical, it's some image scanners we've worked with our partners to change the amount of time for each sequence, which allows us to get higher resolution. We've also changed some of the MRI parameters to help separate out the different soft tissues. We've changed the order in which we do each series, which allows us to make some things work to our advantage. But overall, while I don't intend to stop improving, I think I've been happy since we've been doing this that we're pretty darn accurate. We're providing data that hasn't been available easily from other sources. And we've been willing to review if somebody believes that there's more information on a scan, or there's a question they didn't ask or their doctor didn't ask. We'll always go back and look again at those scans and see if there's further information we can get. Also inside here, unfortunately, because so my wife isn't in the room, so I'll admit a little obsession. I see things now that I didn't see before, and that's just from lots and lots of experience reading thousands of scans and probably 1 million images. So without being too technical, I think we continue to improve, and hopefully we can continue to find new doctors around the country who use us so that we provide more services and options for our patients like you. Thank you, Michael. All right. I want to also remind people that we have a new guest speaker. It's a really fabulous guy. Art Jenkins is a really brilliant surgeon. He's a spine surgeon with tremendous experience. And I've been working with him recently on a number of projects to write some papers and to really develop what we do as a team. He's located in New York City and in Westchester County. He's going to talk about the clinician's point of view about why diagnosing TOS is so difficult. And I presume that's why he works with me, so that the MRI images and my knowledge about the disease can help him make good decisions. He's a really interesting speaker. He knows an amazing amount about TOS, and it's a completely different perspective than our other guests have been, like Dr. Newkirk, the neurologist, and Steve Talikowski, the physical therapist, and different than me. I think you'll find it interesting that he'll have some different ideas than all of our guests, and you can compare and contrast. And you can ask him what he thinks about some of our ideas and how he reconciles those ideas to keep his worldview of TOS. Okay, we have a question from a patient with whom I just spoke today, who asked me a lot of very challenging questions. Terry says, are you able to see damaged tissues with MRI? For instance, the LMT notes that the tissues in the left side of the neck feel different. There are lots of adhesions compared to the right side. Can you see this? Alrighty, so there are some papers that have been published from about 20 years ago that showed that people who had car accidents, if you took samples of their scalene muscles and you looked at them under the electron microscope, that you could see changes in the microscopic structure of these muscles. You could see that the fiber types, there are different types of fibers. Basically, some are fast twitch, some are slow twitch, but longer acting. And they're surrounded by fibrous tissue or a fibrous skeleton within the muscle. So their studies showed that patients who had car accidents and didn't get treated right away would have a change of the muscle fibers. There were more of the slow muscle and less of the fast muscle. And the fibrous skeleton had increased in volume, almost doubled in volume. So from electron microscopes, we know that damage to the muscles can cause a change. These were in chronic patients, granted, not just from a one-time injury. We don't know exactly what happens in patients who get a sudden injury and then recover. But we do know there's a possibility of these soft tissue changes. Now, MRI doesn't have the resolution of electron microscopy, and it's not intended to do that. So we can't see the inner structure of a muscle, for example. But what we can see often is that the muscle is bigger in size, or maybe it's smaller in size. Sometimes with nerve damage, the muscles get very atrophic or small. The muscles can develop fat infiltrating into them rather than a normal healthy muscle. So it doesn't matter as much to us when we're looking at the path of the brachial plexus to know whether the muscle has changed on a microscopic level. What's important to us is how much space is the muscle occupying? Does it take space away from the brachial plexus or the blood vessels? That doesn't take away from the importance of knowing that the muscle may have changed. And this is why I'll always tell people, my MRI is not 100% be all and end all. It needs to work. It needs to work with a good clinician, a physical therapist, a surgeon, a neurologist. We need to put our heads together, often more than two, to figure out what's going on and figure out the highest likelihood of whether you have the disease or not, and then to plan from there whether surgery or conservative therapy is indicated, and if surgery is, what type of surgery. I hope I answered your question well. Let's see if I have anything new in terms of questions. I'm trying to learn how to use this live streaming, so bear with me. I'll check my phone too to see if we have anything new coming in. And Herb, who's moderating this. All right, looks like we've answered all of our questions. Again, I encourage you to follow the toseducation.org website. They have done a tremendous amount of work putting together these people from different specialties in different parts of the country, which has been great for me to learn from these people. I hope it's been great for all our viewers. You can also reach out to us through YouTube, reply with comments, and we get back to people, or come to my website, tosmri.com, and go to our Contact Us page, which is in the last tab over to the right. And go down that last tab, and you'll find Contact Us, and you can fill out a form. We respond to those as well, after which we can have a phone call or email to add more details. Remember, we have Art Jenkins coming up. He's going to be a great speaker, be something very interesting and different from what we've done so far. So I want to thank each and every one of you for attending and viewing. Thank you to the people who asked questions. It's really encouraging for me to see that we have a lot of smart people who've learned a lot on their own about TOS. We hope we help you learn more and point you in the right direction to keep reading and asking questions. Remember, I always encourage people, empower yourself through this knowledge. If your doc won't help you with the decisions, Okay. Just make the decisions more educated with yourself and a partnership through your doc. And you know what? I'm being told we have another question being added. All right. Marion says, I'm coming in late. So a random question. Is cervical dystonia common after bilateral first rib resection? So the most common surgery for thoracic outlet syndrome is first rib resection. There are many ways to do it. Surgeons will remove different parts of the rib, and they'll take different approaches. Some doctors will do a supraclavicular approach, coming in over the clavicle. Some doctors will do an infraclavicular approach, coming underneath the clavicle or collarbone. Some doctors do an endoscopic robotic surgery from inside the chest going straight up. Some docs will do a transaxillary or going through the armpit towards the first rib. So to answer that question, first thing would be we need to know the approach that the doc took. Secondly, I would think it would be important to get a TOS specialist to assess this cervical dystonia in more detail. In other words, what type of pain is it? Are the nerves involved? And then, while I don't encourage people to get imaging and make that choice on their own, I encourage them to get their doctor involved in the decision. We are certainly glad to help with additional imaging following surgery, which we get asked to do a lot, if your doctor thinks that that's indicated. Okay, I don't want to be the one who sells our study. I think it's great, obviously, patting myself on the back if I was more flexible. But we always think it should be a team that works through this, meaning the patient and a clinical doc like a neurologist or a surgeon and me to make that decision. So Marion, I can't answer your question directly without more information. If you want to reach out to me and contact me, I will help you sort it out and find people who can actually help you narrow down your choices. Again, thank you to everybody. It's really great to see all the questions. I hope we're being helpful with this. And remember Art Jenkins, I've said that like 3 times, but you'll love him. He's really good. I will be back in the not too distant future, as will Steve Talikowski. And I think we have Fareed Garagazlu coming up, who has, again, a different approach to this. It's very fascinating to compare with what we all else do. So thanks again. I look forward to seeing you soon. And come back to our YouTube page because I'll be posting some more educational videos myself that I produce on various parts of TOS, as well as a couple of case studies and some talks about the history of TOS, which to me is just fascinating. So everyone have a great evening. Thank you again. I look forward to seeing you soon.